so that's...
Can I ask Ricky the question?
You may. Is this your phone, Rich?
Yes, it is. Oh, and I forgot one point, but we can come back to it. No.
I'll manage the afternoon time.
Okay. So there was one other point, because I think it was Michael who, again, talked about the opioid issue and the pain issue. And I just wanted to say that here at the center, we are working on that issue. And we have this program called PAINS. And I'm going to leave it to Tracy or to Myra to give the whole acronym. But the mission statement of PAINS is the following. And PAINS, this is an alliance of pain advocacy organizations, and we're actually trying to influence perceptions, public perceptions of people in pain, and we're trying to do this in the face of a concurrent public health crisis of the opioid epidemic, which is essentially taking the oxygen out of everything else in this area. But our core message from the PAINS, P-A-I-N-S program is that comprehensive chronic pain management, and we need to advocate for that. That is, not just giving people pills, but having people have access to physical and behavioral medicine services to address their chronic pain. Comprehensive chronic pain care will improve the lives of millions of Americans because, in fact, we documented chronic pain affects nearly 1 in 3 Americans, 100 million Americans, from 25 to 30 million with high impact chronic pain. So chronic pain will improve the lives of millions of Americans, save billions of dollars. We know this is a $30-40 billion problem, and reduce the abuse of opioids, because one of the things that happens is that it's often easier to prescribe because there are really no other options for some people. So I wanted to make that point that I thought that Michael was really onto a really important thing, and that's one of the programs that we are doing here at the center to try to address this. So thank you.
Myra, you have, and then we've got a question at the back. So I'm looking for some helpers because we have a mic we can run, and we certainly should when we get to the... Yeah, but we're trying to pick it up on an audio too. So we'll get a mic to Myra and then run a mic.
And I have my own mic.
So Myra, we can...
Oh, Myra was first.
Myra's first. Myra, I'll bring you this mic. I'm coming over.
But
I'm demonstrating my walking skills. Okay.
Richard, I want a point of clarification. You threw out the comments of a number of others in bioethics. I'm much more interested in what you think than what Gil Mylander thinks. I've hardly ever agreed with him on anything. But his comment, which you quoted, about perhaps it's a good thing to burden others as we're dying, lest we tempt to injustice. And then the further comment about all the good it will do his wife to be his caregiver, I found completely offensive. And particularly when I thought about the scenario, the case that Shelley presented with the African-American grandmother and her granddaughter, and the implications of being a caregiver for her grandmother, what that would mean. You know, for Gil Mylander's wife to be his caregiver at the end of life, she may have to drop out of bridge club for a while. For this granddaughter to take care of her grandmother may mean that she has to forego educational opportunities to find a life partner. So I want you to comment on that.
Or not. So we have different views here. So I'm taking the term burden in a little different sense than what you are saying. And of course, there was a play on words to kind of make this point. I mean, it was a play on kind of perhaps the varying and nuanced meanings of that word. But I think now he's clearly a professor of religion, and this is coming from a particularly, I think, theological perspective that life is about community, and in the context of one's faith life, we take on an obligation to care for each other in community. So I didn't find it offensive at all, because I want to be burdened with actually going through the difficult and thought-provoking decisions that are required for me to share the love I have for my family. So I see it totally different. You know the story of my Aunt May. I lost my aunt, who was 103 years old. African-American woman, grew up in rural Georgia. She actually, she was the oldest living graduate of Hampton University before she died. I like to tell this story because it just kind of shows you how the world has changed. So here you have this woman, 103 years old, growing up in rural Georgia. She is at a commencement service at Hampton University, in which she's the oldest living graduate. None other than President Obama is giving the commencement address, and called her out, said, "We have the oldest living graduate at Hampton University here." We got home, we said, "Aunt May, wasn't that wonderful? President called you out." She said, "Oh, he can't be the president." Now, she was suffering from Alzheimer's, but it was, in many ways, as we talked to her, it was inconceivable to her that Barack Obama could be the president. But Terry and I had innumerable conversations with Aunt May about writing down what you want done. Aunt May, you're 85 now, you're 90. Write this down so we know. I trust that you'll take care of me. You'll make the right thing. But Aunt May, I could be in Kansas City and something happens to you. I trust that you'll do the right thing. And she was of this generation, of course, who had a lot of suspicion about how things in writing could not necessarily be used to help you, but could be used to further marginalize you. So we took on that burden happily. So, Myra, I just have a little different view. But now, yes, I think but we did have discussions, right? And so I think I'm using the term burden in a slightly different way, I think, than you want me to use it. I'll put it that way.
So I'm going to do a quick question from the back. Don, do you have slides too? You've got a hand up. You don't have a slide. And then, do you want to come up here and talk, or I'll just talk. Talk over there? Okay, so we'll do that, and then we'll get a mic back to Don over here. So.
Okay, I've got a couple quick questions on the opiate epidemic. I like what you had to say about that, Richard. Obviously, everywhere you turn, there's a lot of talk about the opiate epidemic and how extreme it is, obviously. So I want to connect that to the idea of trauma in our society. The CDC is in the process of doing their nationwide studies on using the ACEs program to identify the extent of trauma, not only within individuals but within communities. And in studying this, as a professor, I teach at Park University here in the MSW program, but I've practiced therapy for a number of years and specialized in addictions. Mm-hmm. And what I have seen over the years is this tendency to go to whatever substance is available to self-medicate, to deal with not only with trauma, but trauma so oftentimes turns into chronic pain. Mm-hmm. And the last few years I've been practicing mindfulness-based therapy, and I've done a lot of mindfulness meditation. I know at the University of Mass, the John Kabat-Zinn has done a tremendous amount of research to demonstrate the effectiveness of mindfulness in treating chronic pain. And I know also that I've used hypnosis with some success with people with chronic pain. So I'm interested in your thoughts about the alternatives to opiates and medication, what you think about mindfulness in particular, what you think about hypnosis as a treatment, and your thoughts on the connection between trauma and some of the epigenetic hypotheses and research that's coming out now.
Right. Well, certainly true that a significant percentage of the population of people with chronic pain have gotten to that point, and we're now talk about the disease of chronic pain, not just chronic pain as a persistent symptom, but actually is something that is occurring that has physical, emotional, as well as social consequences. And so I'm agreeing with you that trauma is a huge issue. Secondly, when we say access to comprehensive pain management, we are talking about the very kinds of things you were talking about. Access to behavioral medicine, psychologically based, or approaches that are done by psychologists that are in the cognitive behavioral realm. We're talking about physical modalities of therapy, acupuncture, those kinds of things that focus on treating the physical consequences of pain that are not medication related. So the injustice is that that very few patients who need those services actually have access to them because they're so few and far between, because essentially no insurer will pay for the kind of comprehensive array of services that people need. So I think we have a big job at advocating for access to that.
So I need to get Dawn. I'm already late. I want to make sure. So let me get to Dawn. I do want it to be conversational, but I don't want to not get to Dawn. So let me do that. So I've got Stephanie and Michelle, who are my panel afterwards. We're going to make sure and get you 30 minutes, but we're going to run this one a little bit longer because I want Dawn to have time. If we have time to come back, I will. I'm just trying to get it all in this afternoon. Dawn, take it away.
Well, thank you, Kathy. Looking back over my time in bioethics, there are two things that I think are most important to inform what I'm talking about today. The first of those things is part of the project that I was involved with the Institute for Human Development. As part of that project, a group of adults with disabilities met over months and months and months with a group of people that included Shelley, included me, and most importantly, included a man named Mike McCarthy, who was at the Institute for many years and is now deceased. And so after months and months of sort of preparing the soil, we got to the place that we were going to have advanced care planning sessions with the individual members of that group. The individuals were given assignments. They were to decide who they wanted to attend the session. They were to decide what was the general setup for the session was going to be, and third, where the session would be held. The result of that was cinematic. We had people who met with their family in their family's home. This would be their immediate family. We had people that met over supper. We had people that met over lunch with their more distant family. We had a person who met with her neighbors for a picnic lunch. All of these people talked about their health care because they've been practicing talking about their health care for a considerable amount of time. One of the people, and I wanted to say just a word about this, one of the people met in a less cinematic setup, and it worked out not as good as the others. He didn't have much family. The family that he had didn't really know him very well. One of the people that he invited kind of took over the conversation and talked about some form of music. So anyway, when it was over, we decided that we'd kind of add to the process, and the way we added to the process was that I'm going to say that I had developed a document that covered the questions. I'm not really. It's been so long ago that I think I can claim that I developed a document, but it may not be true. It seems like a much better document than something that I would have done. But anyway, I went through it and I asked him a series of questions, 25 questions. And surprisingly, those questions kind of fell into some of the themes that the people that spoke this morning have talked about. So anyway, he talked. I made notes. I typed it up. The next month, I met with him again. We talked through it, and I asked him to tell me if there were any places that he thought he'd like to make corrections. He had a few. We made notes. We typed it up. We met again, and I asked the same question. He said he had one correction. So he made one correction, came back. So this is over a period of 4 months, we created an advanced care plan. So, and that was built on this long series of group meetings that preceded it. My point in this is that when we, us here who are not part of the disability community, talk about having what Myra calls the talk, we tend to be talking about something that is a lot less, frankly, than what the people with disabilities did and succeeded in doing. Now, there are iterative problems with all advanced care planning. Life goes on in ways that you didn't imagine. You need to get back to so there's all of that. But the idea of spending time on something that you think is important is not to be overlooked. This is not the real piece of paper, but I remember, my sister's not here today, so I can tell this story with complete impunity. My father had been diagnosed with a terminal condition. He had told me one time that he had made an advance directive. He was a chronic liar, so when I began looking around in his apartment, I found a tackle box that had, junk. And I pawed through it, and I found a piece of paper. Actually, it was torn from a yellow legal pad, and it said, "No heroic measures." So that would be the extreme end of not paying good attention to your advanced care planning. He could have done a little better. Fortunately, he had me and Mary Beth to put him to bed. So my point is that people with developmental disabilities unquestionably can bring to bear the business of person-centered planning to end-of-life care planning. No question that can happen, but it does not happen easily. And so that's the first part of what I've done that it seems like is important to me. The second thing is that for the last 2 years, I've been hanging with the palliative care team at the University of Missouri. Hanging means they have an interdisciplinary team, they have a multidisciplinary team. Both those teams meet just about every day, and they do some rounding, and I participate in most of that. Over that time, I have read the advance directive of every person who's been on the palliative care service. I believe that I'm the only person that has read any of the advance directives. So the first thing, healthcare, people die. Myra used to talk about how, in the future we were not going to die in hospitals. It seems to me that we're dying more in hospitals, and we're dying in higher levels of care in hospitals. So and these are people that are receiving palliative care. So so the hospital is a reality. And the separation of, at my hospital, if you're seeing someone as a primary care physician and they're doing all of the stuff that we think is the right stuff about preparing for end-of-life care, there is literally one chance that your primary care physician will see you. Our friend, Steve Zweig, who is a primary care physician and still has a few patients, when they hit the emergency room, he gets an electronic message that they've come in so he can walk down. He also has a job as a physician, but he's the chair of a department, so he has the kind of flexibility in his time that he can actually walk down to the emergency room and see his patient. And because he's the chair, even though he's not an internal medicine doc, they let him into the room, into the intensive care room. So he could actually follow his patient. But he's the only person, the only person who can follow who does in fact follow their patients once they get in the hospital. So what happens before the hospitalization occurs is critically important. I was looking at my assignment for today, and there was this line: can a person-centered plan also become integrated into a patient-centered plan of care? We just heard how people can disagree over the meaning of words. And I think that the disagreement that is built into what I just said is so critical and so unappreciated by patients. People ask, I think if people want to know what my goals of care are, they're asking me to say something. But where I work, there are 3 possible goals of care, and they're for the palliative care people. And they don't care. They don't care what I say. They care what they write down. Now, they go through a process to do that. I thought it would be, some of you may remember when Zeke Emanuel wrote this paper, Why I Hope to Die at 75. When I read it, I thought that was pretty cool, but now as I'm getting closer to 75, I'm giving it a little second thought. But my point is that Zeke Emanuel, we all know, one of the biggest time bioethicists, a physician, he's saying a message that's kind of like those of us who remember Bill Bartholomew remember that he said. And it was really I don't want to be around a doctor very much when I'm real sick. But I thought, I had this idea that I would meet with the director of the palliative care team, and he would try to elicit from me my preferences, and what I would be doing would be using the information in Zeke Emanuel's paper to try to express my goals. And when I told Steve Zweig that this was what I wanted to do, he said, "That's great. If when it works, tell me, and we'll get you in front of an audience." But what happened was, Kevin Craig and I sat down and we started to talk, and then we just stopped talking, and we just looked at each other until we got up and called it quits, because what I was trying to say didn't fit into the process that he was looking for, and the process that he was looking for, I was determined to resist. So my point is that it's not just doing person-centered planning. It's not just doing person-centered planning that relates to healthcare decisions, but it's person-centered planning that relates to healthcare decisions and how that's going to work for you, the patient, in wherever it is that you end up. And you can be surprised by that. So those are the main things that I wanted to say, you have a handout that it says process of care up at the top. I stole this. I've always said that I stole it from Steve Zweig, but he says that he stole it from somebody else, but he can't remember who. So I'm saying that here's the slide, and I've modified it some, so it's not even. So that, I guess that's plagiarism. I've plagiarized the slide of somebody who I don't know who it was. But the point the reason that I took that high risk was to point out that what he calls the patient's preferences show up. So the idea of harvesting preferences is something that he intends to do, but it's separate from establishing the goals of care. And I thought, because they were next to each other, that they would kind of bleed together a little more than they do. I don't know what my advice would be, but I do think there is this. The patient-centered care notion has evolved over, I don't know, the last 20 or so years into a pretty finely defined idea that the way Shelley presented it today and the way the other speakers presented it, this is a pretty finely worked out way. It's a good place to start from. And if we grab a hold of that and try to make it work for us in a healthcare setting and try to get the healthcare setting to be more accommodating of what we're trying to do, you know, what the heck, all this advanced care planning stuff might actually amount to something. And that's what I wanted to say.
Thank you, Don. I'm going to ask Rich a question I'm going to segue to the next panel, but let me ask a question, Rich, to you as a way to kind of segue. So the next two people who are going to come down are going to talk about people with Alzheimer's disease. So I called some people to line up today, and I talked to a woman who was caring for her husband. He had a major stroke. She had been caring for him for 4 years. She couldn't come because her caregiving responsibilities were so significant. But she wanted us to talk about something very specific on this panel, which is, what do you do when there's a conflict? What are the ethical issues with conflict? Her husband at this point, having survived a very serious stroke injury 4 years ago, has a different perspective on his own reality and future than his caregiver does. And how do you navigate between the patient and the caregiver and quite literally different realities that they're living in and make it all go? So will you talk about that? It's a good way to segue as we then start talking to people with Alzheimer's disease. He was someone who had survived a stroke, but it's very similar in terms of cognitive impact or impairment.
Right. There's no right answer here except that I think there needs to be continuous discussion and iteration around what the patient understands as what they think they want, the impact of that decision on not just the patient, but also the family, and probably in the end of the day, some kind of, to be real about it, some kind of compromise around what actually gets decided. I think some people would say, well, it's the patient's decision, but I'm actually trying to make a case here that the patient, and it's about patient and community and their family, and the family and community has to live with the impact of that. And, you know, like all others, like some others, like no others, there are certainly cultures in which it is as important for these kinds of things to be resolved in a way that reflects a kind of common community value as opposed to solely what the patient wants. So I think I've been in that situation many times, and in reality, you just kind of keep trying to figure out how you get to the best compromise. I don't know if anyone else would answer that better, but...
All right. let's just clap for you and let you go, and we'll do the next panel. So thank you both very much. Thank you, thank you. They clap when I tell them to. They're very good as an audience.
That's great.
Stephanie and Michelle, I think it works best for our little video over here to have you sit over on this side. So, team of people in the audience, we're going to talk to these two nice women. We'll take a quick break. If you promise to come back, because we're going to beam Lex in, and it's worth sticking around for Lex. I reached out to people who said they would be willing to come just to hear Lex, so I don't want to not have a good opportunity to listen to him. We should connect with him about 3 o'clock. So, hi, you two.
Hi.
Good to see you again. So, Stephanie, I'm going to have you go first and try not to fall over your bags, because then that would be bad for both of us. Stephanie Moore, I've known for quite a while now. She's the former regional administrator at HHS. So she and I worked together at Health and Human Services, but she was located here in the Kansas City office. She stuck around in the Obama administration a little longer than I did. You left in January, so you stuck around to the very end. What she did, the regional administrators were really essential in doing outreach. This particular region is Nebraska, Iowa, Missouri, and Kansas. She did a lot of outreach to provider organizations, did a lot of education about the ACA, was probably burdened in this part of the country with the popularity of the ACA, or lack thereof. But that was what her primary responsibility was. Stephanie is a nurse by training. She's been a nurse for more than 30 years. She's devoted her career to public health and education. She is married to former Kansas Congressman Dennis Moore, and I was pleased to host both of them last night at the annual dinner at my table, so I've known Dennis and Stephanie for a while. I have known Michelle for a long time, too, just because I've been doing this stuff. Michelle works for the Alzheimer's Association, Heart of America chapter. She's the director of education programs and policy. She has been with the Alzheimer's Association since 2001. Her responsibilities include providing and coordinating educational opportunities for all those involved in the Alzheimer's experience, directing program services, as well as assisting in advocacy efforts to address the needs of this vulnerable population. 12 years of her 31-year career were spent in geriatric psych acute settings. She also teaches social work practice at KU. I asked both of them to come because I wanted to return to a patient experience. For the panel this morning, as you saw, I asked them if they would just talk about their healthcare experience. But we really have to at some point talk about people with advancing illness. And particularly in Michelle's case, she has been with people all the way through. And I wanted her to talk about the unique challenges in supporting people and their families with Alzheimer's disease through the whole journey, and have a chance to hear from both of these women as we figure out how to best be person-centered, patient-centered, and support people in these very difficult times in their lives when they're facing advanced illness. So, Stephanie, I said you didn't have to talk about anything, no bullet points, just jump in, and then we'll have Michelle talk, and we'll spend a little time, hopefully do some more engagement with the audience before we beam Lex in from Houston. So, your mic is live.
Should I take it off? Well, good afternoon, everybody. Thank you, Kathy, very much. And Kathy's amazing. For anyone who was at the dinner last night, you heard how amazing she is. I'm surprised your head fit through the door coming in with all the accolades. She is wonderful, and we are very lucky to have her back home here in Kansas and working with this organization for sure. Myra, good job for you, for everybody who helped have that happen. My life right now as a caregiver, full-time for my husband, is probably the most important job I think I've ever had. My training as a nurse helped me to a point. But then you get to that fine line, which I know Michelle and I have talked about, where you're the spouse, you're the family member. I was listening a little bit a moment ago, or I was listening to you, about when it's a burden or not a burden, and that word. And that's going to be an interesting takeaway from this whole meeting is what's a burden? I think that's a whole nother discussion. But, till death do us part, sickness and health, all that business that you say when you get married, with the spouse, when the illness arises, no matter if it's an acute illness, chronic illness, it's Alzheimer's, you are there. You are the caregiver. That's part of your vows, I think, when you marry. So, interestingly enough, I am the caregiver now, morphed from being the I guess being the wife, Michelle and I have had a lot of conversations. Things change. And what does that mean for you, for your partner, for the life you have together, for the choices you make, for the choices you thought you had already made, and how that changes as the time goes by? And when one person actually is making some changes to those decisions, you have to be confident, very confident, that what you've discussed previously, what you know as a caregiver, whether it's a spouse, in my case a spouse, or your parent, a child, that you know those decisions were made at a certain time, and as things progress, things do change a smidge. You honor the decisions that you had made together, but it's okay, I think, to make other decisions that are as important. I think, as I heard the gentleman from Duke, is that right, Duke? I worked at Duke for 2 years, beautiful campus. Yeah, well, there's that. Or Rock Chalk, whichever we want to say around here. But it's okay to make those changes so that you can continue on. Honor that person, what they want, what you know is they would want, and do it in a way that makes the most sense at that time, at that place, for the people involved. Is that what you want me to kind of start off with there, Kathy? Okay. Michelle? Comments? Just on, or am I supposed to keep talking?
No, Michelle, we go.
Michelle, it's all you.
We're going to talk to the audience, too, so good.
Yeah, just to react to that a little bit, I agree that things change. You know, when we make decisions, it is based on a set of variables. And sometimes when the variables change, the decisions change. And for someone with Alzheimer's disease, certainly at more progressed states, they may or may not be able to factor in all the variables. And so there is another layer of, is this decision consistent with a philosophy and a history more than is it literal in terms of what may or may not have been said prior. I want to say something. I filter my thoughts in several ways. I mean, not only have I spent a career working with people with Alzheimer's disease, I was primary caregiver for a wonderful social activist mother who lived with physical disability, and that resulted in her death at the age of 50. And I am the mother of an adult son with autism. So I know the interaction with the healthcare system on multiple fronts, and have lots of thoughts about things said here. One thing I think about in terms of Alzheimer's disease, end of life kind of decisions, this idea about injustice, and I think the term was economic injustice. Certainly the phrase civil rights brought up this morning, I think lives very fully in the experience of end of life and Alzheimer's disease. And I think the people who are most vulnerable to having their wishes deviated from are those who are being represented by individuals that have less resources, whether that be economic resources or whether that be ability to express and advocate, whose skill set may or may not include some of the assertive communication that is required to interact with the medical community. And just real quickly, and you may have some more reaction, so I'm going to turn it back over to you real quickly. Have been recently walking through this journey with a woman who has given me permission to share her story. She's an individual who lost her vision at the age of 18 and has struggled in her life with depression and some other physical problems, lived with her mother, who later developed Alzheimer's disease. Now, they were two against the world. This woman did not marry, did not have children. She lived with her mother. Her mother was a single mother, did not ever remarry. It was just two of them in the world. They had a very close relationship. She knows her mother's desires about end of life. Got to a point, mother had to be placed in a nursing home. mother was placed on hospice. So you understand with me, this is someone who is in the end stages of Alzheimer's disease, daughter who, regardless of the challenges she's lived with in her life, are smarter than most of us, let's put it that way, brilliant mind. She asks a lot of questions, and sometimes a lot of questions to the medical community is not necessarily welcome. True? And so she raised the question, is it time to take mom off her her hypertensive medication? Is it time to take mom off her medication? Hospice, late stage. The facility she was at hotlined her for abuse, said she's trying to kill her mom. Now, she hadn't made a conclusion. She was asking a question. There was never a conclusion. We all understand that if you're in a long-term care facility, a family doesn't walk in and say, take them off all their medicine arbitrarily. That's a process. Requires some agreement. So hotlined. Hospice participated. The physician participated. Went to court, and guardianship was given to the public administrator. So she is a person without resources. She represented herself. That was the problem. I sat in the courtroom with her, and the judge told her very directly, if you do not like it, appeal the case. So I say, appeal takes money. I know, the judge says. We finally did find an attorney that took her case pro bono, and 6 months later she was able to be restored as guardian, her mother, in her last days. So what I say is, I think this woman was not listened to because she asked a lot of questions, a little bit eccentric, we might say, superior intelligence. She didn't have the support system that could appear with her, and she certainly didn't have the economic means. And one other quick thing about that in terms of economic injustice, we should all be concerned about a separate but not equal long-term care environment. When we're talking about Medicaid versus non-Medicaid, we are talking about some quality differences, and we are talking about discrimination kind of issues, and we should all be very concerned about that. And I don't think we talk enough about this very separate and very unequal system that we live in, and it has lots of consequences for most of the world that does not have resources.
I'm going to jump in and ask you both a question. I'm going to refer back to where we started this morning. I'm not sure if you were, I know you weren't, when Kathy spoke to us this morning, and she's here with her father, Richard, and Kathy talked about advocating for herself as a self-advocate with women living with a developmental disability, dealing with providers, and having them look past her, having them look at her father or her mother and not working and talking directly to her. How does someone with Alzheimer's disease navigate in that world? Do people stop looking at the person with Alzheimer's disease and automatically look to the caregiver? I mean, how is the person who is advancing in their illness, how are they still seen and not talked over or around? What's the most respectful and inclusive way for their presence to be in any conversation that's about them in a situation where they have severe cognitive impairment? So how does that work? How do we remain respectful with an individual who's still here and include them?
Well, boy, that's another good one, Kathy. That's a good question. And Michelle will have things I know that she can add to this as well. I have found that Dennis and I, my husband and I, have been very upfront with his Alzheimer's from the beginning. We announced it publicly. We were very public that he had Alzheimer's. We wanted people to know so that when we were out and about and we were having conversations that they would address both of us about it. It was extremely interesting to see the people who would look right past my husband and talk to me. Well, you know that he has Alzheimer's. Well, he is sitting right here. You can talk to him. We know he has Alzheimer's. Ironically, the majority of the people who did that were medical people. They were in the doctor's office. They were caring people who thought they were talking nurses perhaps, or just the technicians in some of the clinics. When we went for some the evaluation, Michelle, that they do, that Dr. Neuropsych, they absolutely talked to me and not him. Absolutely talked to me, and I thought this is the most bizarre thing I've ever seen, because they're actually talking to him about his neuropsych, but they're talking with me. The other thing that I have found folded into this is that we are still, my husband is 70, almost 72, and I am 60 plus, but we're still in that society, in that age group where people look past the wife and talk to the man. We've still got that. An older salesman at Nebraska Furniture Mart the other night insisted on only dealing with my husband. I said, he has Alzheimer's. I am buying the refrigerator. The refrigerator came in the wrong color. It was delivered to the wrong address. So then they left and it came back to our house. They called my husband's cell phone repeatedly because that was the cell phone. You have to really, in those situations, Kathy, you really have to include the person with Alzheimer's diagnosis in the real time. They are there. We're picking a color. We're going to have this delivered. It's all very good. But education is so huge in this. My big pieces are education, health literacy, very important when you're doing the education piece for a lot of folks, and advocacy. We've got to remember that you have to tell people what's going on over and over and over. So that salesman's not going to then sell me the dishwasher, but sell it to my husband. This takes a lot of time and a lot of energy to include the person when you can, but then not. We did just buy a house, I will tell you that, and it was made perfectly clear at closing. Mr. Moore, you understand what you're doing. Yes, I'm buying a house. You understand that it's costing this much money. Yes, I understand it's costing that much money. And in the moment, in the discussion, he absolutely knows we are moving. The house is going to cost this much money. But you talk to him later as we're driving home, and he says, well, are we doing anything tomorrow? Well, yeah, we might be buying a house tomorrow. But in the moment, it's very important to continue to include the person with Alzheimer's disease in those conversations. Fight the battle later, as I've had multiple conversations with Michelle about, man, I'm getting tired of these conversations. And we talk about the many ways you can deal with that. But I think keeping the person involved as much as possible in what's going on. I have sadly, a 44-year-old son who's dying of terminal cancer right now. So telling him every day that Kevin is dying is really hard, but we're keeping him in that conversation. It's important.
I'm just going to chime in. It's interesting. I had a cousin who committed suicide and a grandmother with vascular dementia. And I'm not sure we ever told her. It wasn't my mom and my aunt's decision, but it's very hard. How do we convey this, and what can she handle in those very private family conversations? I hadn't thought about that. Michelle?
Well, I was just going to absolutely agree that part of how we keep someone who has Alzheimer's disease in the conversation about how life goes, especially end-of-life issues, makes the case for early detection. There's lots of folks who do not have the opportunity to be diagnosed early. I mean, we all know people on our average are diagnosed 3 to 4 years into the disease process. And so we have to be better. There are better tools. We've got to use them more frequently to look at diagnosis as early as possible. I love the conversation about taking control. And we talk to lots of people in the early stage, not get your affairs in order. That's a hopeless sounding conversation. It's about you stay in control. And how you stay in control is having conversations about how life should be. But that is best served when people are diagnosed early, when people are brave enough to come forward and say, this is what I'm dealing with and this is what I'm facing. The other part of that is we can never look at anyone in what I call one dimension. So we are all three-dimensional human beings, and there is no easy way to figure out what the right thing is for a person than to look at their history and philosophy and who they are. So that best is representative of what they want as the disease course. So if I say, I don't want to take medicine, when I'm not recognizing the risks and benefits of that kind of decision. But lifelong, I have a family member now with Alzheimer's disease. She's never taken medicine, had a heart attack, and refused to take cardiac medicine. She's never believed in medicine. I don't have any qualms about when she says, I'm not going to take Alzheimer's medicine. That's completely consistent with who she is. Whether I like it or dislike it, that's her philosophy. I accept it. That's different than somebody who's taken medicine all their life and in paranoia and in confusion saying, I don't want to take the medicine. So we have to always be looking at, is it consistent? This three-dimensional person, not the person facing you. Are we representing who they are over the course of a lifetime?
So, everybody, it's after lunch. You all need a little bit of sugar, even though, I was very self-conscious about the chocolate chip cookie, based on Bob's comment. I'd like took a bite after lunch. I wanted to make sure that after starting the morning and getting these concepts, we had a chance this afternoon to at least focus on, think about people with advanced illness and people who are at the end of life. And I just want to have kind of a group conversation. Are there issues swirling around that we need to get out in the air as we move forward from here? Mike, can we run a microphone to, we'll have to get it to Mike because if he comes down the stairs, we'll have an accident. So Cindy can maybe help. I just want to make sure we kind of surface things and then we'll take a break and then we'll get Lex keyed up here. So,
Kathy, can I say one?
Yes, Michelle, go ahead.
I just want to say one more quick thing, and this is in response to Mr. Oxford this morning, as he kind of alluded to on the assisted suicide discussion. We cannot look at self-determination in the context of an excuse because we don't have staff or that we don't have means, and that's the easiest thing to do. And I think about those people in facilities who we say person-centered, we'll let them sleep as long as they want, which is a good thing. I don't want to be woken at 5 or 6 in the morning. But for those folks who do not have the ability to assess what time and who might be depressed, who might not have initiation and motivation secondary to the insults of the brain, to allow them to lay in bed all day under the guise of self-determination. So we have to watch that too, that we're not using that as an excuse for poor care.
And that's the balance that Bob was talking about this morning. Important for, important to. Mike.
It's been alluded to and it got mentioned about there's Medicaid, long-term care, and other, but I just want to bring up the whole long-term care, private long-term care insurance issue and ongoing disparities there. Again, my parents, smarter than me, and bought a policy, get 2 years in a day of in-home support and lifetime of in the institution, and pays for a nice institution, way better than anything I've seen in Medicaid, and I've seen a lot of them. So, kind of even building that thread in. We talked about socioeconomic and so on, but the whole private long-term care insurance thing, I think, is really important in this conversation. I haven't kind of heard it brought up specifically.
Well, in your example that caregiving can be a short period of time, or for some people a very long period of time, depending on the prognosis, and how many people they're caring for. I've heard of people who are caring for people for like decades, and especially that's true then for adults with children with developmental disabilities or physical disabilities. Any other kind of thoughts? I just want to get everything sort of up, and then we'll take the mic to Clay. Yeah.
Thank you so much for your comments and your forthrightness. I've been thrown into a whirlwind that I never imagined. 2 days ago, my father died unexpectedly after an accident, and unbeknownst to me, I knew that I was his power of attorney for medical, but I did not know that I was the medical power of attorney for my stepmother, his wife, who has advanced Alzheimer's. And so with my dad out of the picture and me suddenly being in charge of all of that and being named the trustee of his estate to handle all of the affairs and the management of the 8 siblings who have differing opinions, this conference has been just so important and gratifying to me to hear the experiences and the validation that as I go forward and make these life and death decisions for people and the long-term care and how to utilize the very limited resources that, you know, Mike is talking about, these resources, they need to be out in public and so available. And the people who are making those decisions need to know that they're making the right decisions, that there is not going to be an ethical repercussion. And, you know, in the hospital, I kept asking, are we crossing any ethical lines here? And as I'm working with the decisions of where to place my stepmother, there are really a lot of ethical questions that you as a decision maker have to take in. And so I commend you for doing what you're doing. I beg you for other people's purposes, please continue and make these voices, make your experiences known and just available to people to understand what they really are going to be faced with when they say to their parent, I will be your medical power of attorney. Thank you.
Thank you. Our condolences to you. Your father died very recently, so thank you for being here, helping us. Clay? Yeah.
Clay Anderson, palliative care physician, hospice physician, and amateur clinical ethicist, St. Luke's here in Kansas City. A really very interesting, fascinating, I also think challenging day for me in that most of what palliative care and hospice physicians do doesn't intersect with the disabled community that often. And, you know, I think we're kind of blending some languages and some ideas together, and I just think it's a very fruitful and potentially productive area. For the ethicists that are here, I've been thinking a lot, you know, I come from sort of the autonomy and surrogacy, old-fashioned ethics background, and I was just kind of getting used to shared decision-making when all of a sudden supported decision-making was sort of thrown at me as a new concept. Similarly, I've been thinking about consent versus assent, meaning clearly we want to meet these people's wishes. We want to know about them as human beings. We want to continue to go along with and enhance their definition of their quality of life. And yet we know that there's a barrier between us and them in terms of their ability to understand information and process information. And so I think, and we even talked about someone with a guardian still being able to participate in their consent, either through, you know, shared consent or supported decision making. And so I think in a way what we're doing is we're translating or transforming that old language to apply to both the realities of 2017, but also the lived reality of persons and families with intellectual disabilities, which from our world, you know, the hospital world and the hospice world, you know, the system is not really set up really for supportive decision making, and yet clearly we're seeing that it's something that we need to be ready for, to deal with, to learn and understand. And so I think a little of that crosstalk between those two worlds, since a lot of the right people are here, I think would be helpful. And I certainly can throw in a few other questions, but I just wanted to make that sort of sense of where the ideas are meeting together so that maybe we could share a little more in that arena.
Thank you, Clay. Run that back. You know, another kind of dynamic that's pulling these issues together is that we have a longevity benefit for all of us, including people with disabilities who are living longer. And so, you know, the risk factor for people with Down syndrome from Alzheimer's disease is very high. So we will have people grow old with disabilities and die with the maladies of aging as everyone else does. So it's all of these factors are kind of pulling together as a convergence. So let's see. And then let's do this last question, and then we'll take a break before we come back for Lex. Myra, are you going someplace? You're going to do a question?
No, I want a question.
Oh, well, we'll have to do two. So go ahead.
Mine were just sharing a few thoughts based on some of the things that were being talked about. So, just a quick perspective on that experience of someone with resources as compared to the someone without resources, where my grandmother was receiving community-based palliative care, and my parents the entire time were terrified that even though she had Parkinson's and congestive heart failure, that she was going to be addicted to the medications, right? So even just, right, that wasn't a piece that was, right, this was an absolutely normal part of care, but that fear remained through her entire care experience for my family. And then one of the most important things on her advance directive was that she didn't want a feeding tube. And I was gone for 2 hours, and I'm back, and guess what's there? Okay, and this is someone, right, with 10 years of experience in advocating for palliative care. I can't get that from my own grandmother.
Yeah, very hard.
So, you know, I'm just throwing that out there as where we are for people that understand how important these issues are, and then how does that apply to everyone else who have all of these other barriers to getting that care that they need. Another thing, just super quick, I saw a professor at Santa Clara speak, and she's a bioethicist professor. And she talked about her experience as a daughter of, she was one of 4. And this is her profession, right? And all of the siblings were aligned in the advanced care directive for their mother. And still, when it came time to be implementing those wishes that were documented and discussed as a family, how hard it was for her still to be making that decision. And she just was emphasizing how much the regular care experience for Americans today is to try to be making that decision often with 10 minutes in chaos and without having any of those discussions ahead of time. So just sharing a few of those things for food for thought. So thank you, everyone, for all of your shared experiences today and driving these conversations.
Thank you. Myra, we'll give you the last word and we'll take a break.
Clay, I wanted to comment.
Oh, I'm sorry. I didn't.
I'm sorry.
Oh, the microphone moved, so I lost track. So,
Myra, you can go, and then I'll go. Okay, you'll come behind me. Okay. I just wanted to comment, Clay, to your question, really, about kind of the logical connectedness between the work we've been doing, a lot of us have been doing for many years around palliative care, end-of-life care, advanced care planning. As we look at the reality of the graying of America, the aging out of the baby boomers, and we recognize that by the time any population gets to be 80, about a third are going to be living with diminished capacity for whatever reason. It's really one of the main reasons we are so excited about having Kathy with us. And it really allows us, I think, to kind of push the edge and push ourselves into really what is uncharted water for us. Stephanie, I want to ask, with your permission, and I would only do this because you and Dennis have been so open about his diagnosis and the journey that you guys are on. I've known you for a long time. I've actually known the congressman longer. He and I were talking last night. I met him when he was prosecuting attorney when we first moved to Kansas City 40 years ago, and have always had great respect and admiration for both of you, and have been grateful for your support of the center over the years. Last night, I was eager to say hello to him. I hadn't seen him for a while. And he didn't recognize me, and that wouldn't surprise me. Anyone in the room might not have, because it was a big room and lots of noise and all of that. But he said, "Oh, Myra, I'm so thrilled to get to meet you. Do you have a card?" I did not have a card with me. But he said, "I'd really like to have coffee and know more about your work." And I said, "I would love that. Let's get Stephanie, and let's the three of us go have coffee, and I'll update you on what's going on." The conversation today about people talking to the family, looking past the person, In situations where you have a person who is struggling with capacity, now the congressman has got a lot more capacity than I have right now, I think, as I assess his ability. But when you realize that that person and a family caregiver or family caregivers are so interdependent upon one another, my question to you is I would pray God I never look past anyone, but is how do you manage that conversation when even with something simple like coffee, I thought, oh God, Stephanie is going to kill me if I set a coffee date because it's going to mean she's going to have to be involved and so forth. So I really would ask both of you about, I think one of the reasons people look past individuals is they don't know how to manage the conversation. So I'm asking the two of you for help in how do we communicate really when it is no longer an individual in one sense, but it is a synthesis of people, the person with diminished capacity and the person who is supporting them and filling in some of those gaps for them.
So Kathy, before you do this, I'll give this right back to you. The PowerPoint's going to go down. They're getting us ready for Lex, but we can still keep talking. Okay.
Well, Myra.